Well, thank you everyone for joining another lecture in this distinguished lecture series. Very pleased to introduce Professor Walter Orenstein today. I'm not going to tell you about his titles or his accomplishments. I'll relate a more personal story. The first time I met Walt, I was still at ICGB and we had gone to Emory to negotiate a partnership between Emory and ICGB. And at dinner, I was sitting next to this gentleman who started asking me where I was from. And I told him that I sort of grew up about 3 hours away from Delhi in a small university town that you wouldn't know. And then he turned out and said, "Oh, is that Aligarh?" I said, how come this person in Atlanta knows about a town which many people don't know about? So it turned out that Walt spent time there as a young medical student, or maybe just after medical school, working in the smallpox eradication program. And then as we got talking, it turned out that he lived in the university guest house there, which was one house away from the house where I was born. And I lived till 1968. So how about this being a really, really small world? So Walt, it's always been a pleasure to know you, to hear you, and we look forward to hearing you today.
Thank you very much. It was a pleasure for me to have met you and talk with you and remind me of all the things that I learned while in India. And I'll show some slides on that. Developing safe and effective vaccines is very important, but is only the first step in mitigating or eliminating diseases that can be protected against by vaccination. Vaccine dose that remains in the vial is 0% effective, no matter what the clinical trials showed. Vaccinations save lives, not vaccines. And just to go over what Professor Jamil was talking about, I went to India in 1974 and as what was called an Epidemic Intelligence Service officer. And I worked in 2 places, in Gonda, in rural areas for 2 months, and in Aligarh for 2 months. And I had a lot more hair then, but this was a very special thing because it changed my entire career. I was just taking a little time off because we had a service obligation in the United States at the time to spent 2 years, and I was going to do that through this Epidemic Intelligence Service, through our Centers for Disease Control and Prevention, CDC, and then go back to a career in pediatric nephrology, kidney disease. And then I saw this terrible disease disappear before my eyes with a vaccine, and I went into a career in vaccinology. And this is smallpox. And this is a very sad picture. This is Shanti, daughter of Pyari Lal, who was 7 months of age at the time. I took this about an hour to 2 hours after she had died from an unusual complication of smallpox, late hemorrhagic smallpox, and in Pathar Bazaar in Aligarh, India. And she turned out to be the last case of smallpox in Uttar Pradesh. My focus today will cover 3 major topics: the importance of herd immunity on community protection, how measles was used to build the overall immunization program in the US and perhaps can be a model for other countries like India. And third, the need for and the how-to measure vaccine effectiveness in observational studies once vaccines are rolled out. Vaccination is one of the greatest success stories in public health. The CDC in US looked at going into the new millennium, what were 10 great public health achievements of the 20th century, and immunization was one of them. And the only human disease ever eradicated, smallpox was eradicated globally. Polio has been eliminated in most of the world. We have some potential for measles and rubella elimination. And in essence, it's a prevention that only requires a couple of steps, being immunized with the recommended doses, and does not, for example, require changes in behavior for a lifetime, which many of the other prevention services require. So when we go to herd immunity, I want to first talk about the induction of immunity itself. Is one, there's individual immunity, and that's where a susceptible person's immune system is stimulated and provides protection against the disease, so that ideally the person not only gets disease, is protected from disease, but also is protected from shedding the virus or shedding the other pathogens to others. Herd immunity is indirect protection because a susceptible person is not exposed to the infectious agent. However, the susceptible person could get disease if actually exposed. And who are the people who are indirectly protected? People who are not eligible for vaccination, such as people who are too young, but who are still susceptible. People who have medical contraindications to vaccination, they're protected directly by herd immunity. And people who may not make a protective immune response are indirectly protected by not being exposed. In essence, I prefer the term community protection because the people who are being protected are not truly immune. It is they are protected through community, high levels of immunity to prevent transmission. Now, one key concept is something called the basic reproduction number. And the basic reproduction number is the average number of persons a transmitting case would transmit to if that transmitting case lived in a community that was 100% susceptible. For infections that lead to permanent immunity, such as measles, the R0 can be estimated by the average age of infection and the average life expectancy. So one divides the average life expectancy by the average age of infection. And what may be a better estimate is 1 plus the average age of life expectancy and the average age of infection. And this just shows you symbolically what happens when you have low vaccination coverage and a lot of susceptible people. You have transmission. And on the other hand, if you have a high level of community, the likelihood that a transmitting case would find the susceptible is markedly reduced. And hence, here you have an ongoing outbreak, whereas in this setting, infection is prevented from transmission. And this is another way of looking at that. This is where there is an R0 of 4, okay? So here you have susceptible people, and here you have immune people. If you have 75% immunity, then 3 of 4 people will be immune, and hence the average transmitting case will only find 1 susceptible, and you will have level transmission. If you go above 75% in this case, the average transmitting case will transmit to less than 1 person, and the transmission will die out. And the formula for calculating the herd immunity or community immunity threshold is R naught minus 1 over R naught. And just to give you an example of the meaning of this, these are numbers of cases one would expect at different R naught levels in 10 generations of transmission in a fully 100% susceptible population. And what you can see here is with an R naught of 2, one would expect 1,024 cases in that. Doubling that R naught, because this is an exponential thing, would lead to over 1 million cases in that population. And this just shows you the relationship between the herd immunity threshold and the basic reproduction number. And you can see here, when you start getting up to 3 or 4, you need very high herd immunity thresholds. But when you're at the high basic reproduction numbers, there isn't that much difference in what the herd immunity threshold is. The other issue is the herd immunity thresholds can be misleading because the herd immunity threshold is not homogeneous. You have crowding in places which require a higher herd immunity threshold than in more sparsely populated areas. So, for example, in rural areas, the herd immunity threshold may be substantially lower than densely populated urban areas. A study we did in the United States back in the 1990s showed that the school age, to eliminate measles in the school age population, we needed a 93% immunity level. But when we looked at if we achieved that 93% immunity level in school age children, we could get by with about an 80% level in preschool children because there was a lower force of infection in those kids than in the more densely populated school populations. Next slide, please. Well, I got it here. Okay, and the ultimate is rubella. Rubella was very important in countries like the US because of a pandemic that led to 1964-65, that led to thousands and thousands of cases of children infected with congenital rubella syndrome. When rubella vaccine came out, we were concerned about giving the vaccine to pregnant women, which is the group that we wanted to protect, because it was a live attenuated vaccine. We didn't know if it would cross over and infect the fetus and cause congenital rubella syndrome itself. So we took a herd immunity approach. We vaccinated the entire rest of the population to block transmission, and it led to eliminating rubella and congenital rubella syndrome in the US. I'd like to move now to measles. And measles has played a major role in countries like the US in getting support for the overall vaccination program. And why? One, it is highly contagious. It's the most infectious of the vaccine preventable diseases. If you have an immunization program that can get enough individuals vaccinated to reach herd immunity thresholds against measles, you should be able to vaccinate against any other diseases and get rid of them. Number two is, while in contrast to smallpox, where it was very easy to be sure, there was a distinct clinical syndrome of a rash illness with fever and respiratory symptoms. Third is, you didn't have to worry much about asymptomatic cases. Virtually all of the cases would be clinically apparent. But clinical diagnosis was not good enough, and one needed good diagnostic tests were available. The other thing about measles was episodic in nature. And while that can be very frustrating from a political will point of view, it could be very helpful because measles would go down. You'd think, oh, we've got it under control, and you divert resources to other things. And lo and behold, susceptibles would accumulate, and then you'd have another epidemic. And so measles was helpful in pointing to the fact that you can't abandon your efforts to continue to vaccinate when disease is low. You needed to continue it. And because measles was common, there were substantial numbers of complications, including hospitalizations and death. And this is a slide from a textbook I co-edit called Plotkin's Vaccines. And what you can see here is the basic reproduction number for a variety of vaccine-preventable diseases, and then the crude herd immunity thresholds. And you could see here that measles is the disease with the highest overall herd immunity threshold. And measles was not trivial. This is also from Plotkin's Vaccines. And you could see here in an industrialized country like the US, 7 to 9% had ear infections, 1 to 6% pneumonia, 8% diarrhea, 1 to 4 encephalitis, many of them left with permanent residua, subacute sclerosing panencephalitis, and death. In the lower and middle income countries, death to case ratios were substantially higher, 2 to 15%. Pneumonia was the most common cause of death, diarrhea the second most common. Blindness in areas with vitamin A deficiency was a problem. And it was estimated that measles caused over 100,000 deaths annually and over 1 to 4 per 1,000 cases of neurological complications. So the initial strategy for eradication of measles in the US was routine immunization of infants, immunization of kids we missed at school entry, surveillance, and epidemic control. And what led to this in the US is measles was the first new vaccine available after an establishment of a national or federal immunization program in 1962. So the goal was, can we ride the back of measles eradication or elimination, which it should be in today's terms, and build an overall system. At that time, worldwide eradication was not an initial vision. And the impact of measles from the program that was called eradication, we would now call elimination, showed a greater than 90% reduction in measles cases. There had been over 500,000 reported cases annually in the pre-vaccine era, down to 22,000. And actual cases were probably in the millions, since the birth cohort was about 4 million and virtually everybody got measles. And with improved reporting in the vaccine era, the actual reduction was likely a lot greater than 90%. But what happened then is the funding for measles got completely switched. They said, oh, this is great, we can live with this level, and was switched to rubella, which was a new vaccine available in 1969. And what happened was a big resurgence of measles. And we saw big problems, resources decreased, and then we had another resurgence. So it just was problematic, but it was helpful in getting the political will. One of my mentors, Ciro de Quadros, and others who were at Johns Hopkins University used to say the P in public health is politics, political will, and getting political support. And so between 1969 and 1977, where there was a diversion to rubella, people were looking at other diseases, and smallpox was eradicated not with a mass vaccination issue, but was an outbreak control strategy. And the feeling was, could we get rid of measles with a similar strategy? And demonstrating measles could be eliminated from the US could set the stage for potential worldwide eradication. Another thing we found is that school laws, school mandates that children attending get vaccinated could make a major difference in controlling measles. We found, and as I've said repeatedly, we needed a continuous source of funding, and that surveillance was critical in changing and finding a change in the age pattern of measles and a focus, and that we couldn't just measure immunization coverage, we needed to measure disease, and that political leadership was critical for success. Now, this turned out to be a complete failure. One, if you look at it, measles was not a perfect illness. There was a lot of other things in the differential diagnosis. Smallpox, I didn't need a laboratory when I worked on smallpox. I could make the diagnosis. Measles was substantially more contagious than smallpox and needed a substantially higher herd immunity threshold. With smallpox, very, very rarely would there be transmission before onset of rash. With measles, it was common. Smallpox was a single dose was very effective. With measles, we needed 2 doses. With smallpox, you could tell who a vaccine failure was versus a vaccine success because there was a scar or no scar. With measles, you'd have to get a blood test. It was not easy to differentiate. And this is an example of an outbreak investigation I conducted back in the late 1970s, mid-1970s, in West Virginia. And what you see here is the connections were just tremendous. Church contacts, neighbors, people who went to music lessons, transfer students, et cetera. The village approach, the surveillance and containment approach for measles was not going to work like it worked for smallpox. Another big issue was the need for surveillance and political will. And this is what happened in Los Angeles County in 1977. In mid-January, an outbreak was detected. By mid-March, there were 2 deaths, 3 cases of encephalitis, and multiple pneumonia cases. By the end of March, the health officer in Los Angeles County was so frustrated because voluntary vaccination efforts were not working. People were not getting the vaccine, and transmission was continuing. And so at the end of March, she issued an exclusion order that if you didn't have evidence of measles immunity of vaccination or a doctor's diagnosis of measles, you would be excluded. And then in April, clinics in most schools at night, clinics in most schools at night and weekend clinics were held so to make it easy to give access to vaccine. But about 50,000 children still had no evidence of measles immunity. And so 50,000 of the 1.4 million students in Los Angeles school children were out of school, were sent out of school and back home. They quickly got back in school. Many of them were vaccinated, but it set a precedent that we could then apply to other states in the United States. And in the United States, we don't have a national mandate, it's by states. But these are some of the early data in 6 states that had early mandates versus the other states that did not. And you can see here, before the mandate, they were very similar in incidence rates. But within a couple of years, they had about a 15-fold decrease in incidence. And this led to every state in the United States enacting mandates for school attendance that they had to have immunity to measles. The other thing that was very important, as I said, was epidemiology. And you can see here that measles was not uniform. We'd have our school-age population in blue, the 5 to 19-year-olds. Here, the big problem in the early 70s was in this population. And then we took care of much. I'm sorry. Hello? Hello? Is there a problem?
Oh, can the audience please mute themselves? You're causing disturbance. Sorry, Walt.
Okay. And so you can see here that the 5 to 19-year-olds were the big problem, and that's where the mandates really took care of things. But we had measles in other populations, our preschool population and our post-school population. And those required other interventions. For the preschool population, we had a big resurgence of measles in the late 80s. And the big problem there was lack of access of young preschool children to vaccination and financial barriers. For school-age kids, we had an upswing. And the problem there was that one dose didn't give high enough immunity levels in a school where there was a high force of infection. So we had to implement a 2-dose schedule. And then in the post-school age, we had problems in college students, for example, and we had to implement mandates in colleges to bring things down. And this just shows you that there were big differences in two groups. This is preschool outbreaks, where the proportion of cases was predominantly preschoolers versus school-age outbreaks. And what you can see here is in the preschool outbreaks, many of the cases were younger than our routine immunization status. Vaccine failure was not an issue. And so what we did is to lower vaccination rates and remove barriers. But in the school-age population, the big problem was vaccine failure, and hence the need to offer a second dose. Now, one of the things also was taking advantage of political opportunities, looking for ways to measure access of care in the healthcare system. There was a group called the Children's Defense Fund, which was interested in healthcare services for poor children. And they wondered, what is the one medical intervention recommended repeatedly for all children? Injections, immunization. And they felt the best way to measure access of poor children to healthcare was to measure their immunization status. And immunization was readily measurable. And the Children's Defense Fund issued a report warning of the dangers of low immunization coverage. We had something called the National Immunization Survey at that time, which we didn't trust. It was based on parental history, it gave low immunization coverage levels, and we thought measles was under good control. And my initial belief was we should blow the Children's Defense Fund out of the water, that they were using faulty data and things were really good. And the best advice I ever got in my career was my chief administrator, who said, if there's one thing you don't do, you don't blow the Children's Defense Fund out of the water. So we invited them to our national immunization conference. We became instant allies. And the board members then played a pivotal role in future administrations. Now, what helped us is this resurgence that I showed you about, where there was over 55,000 cases in this 3-year period compared to an annual average of 3,000, 123 deaths, 11,000 hospitalizations, and the two groups I showed you, unvaccinated preschoolers and vaccinated older children. And the main, and what happened was it turned out that Hillary Clinton, who was at that time, the First Lady of the state of Arkansas was a major board member of the Children's Defense Fund. And when she became First Lady of the United States, we got a major immunization initiative. Now, this is preceded by our National Vaccine Advisory Committee, who looked at measles, and the primary cause of the resurgence, they felt, was the failure to vaccinate young preschool children on time. We also learned by doing implementation science research that many physicians' offices and clinics were missing opportunities to vaccinate children, either, for example, using invalid contraindications not to use it. For example, children with a cold could get measles vaccination, other reasons for opportunities. And there are other programs for poor children which were never linked to immunization, such as access to food that could be linked to immunization. And problems, particularly for children who saw private doctors, they couldn't afford to pay for the vaccines. Could we deal with vaccine access questions? So recommendations were to improve the vaccine delivery infrastructure, eliminate by legislation, if necessary, underinsurance, which was insurance that didn't cover immunizations, health insurance, develop coalitions, which was very important because I, as a government official at the time, couldn't lobby the Congress, our legislators, our parliament equivalent. But we could, if we developed coalitions, get them to do it. And then we also recommended issuance of standards of immunization practices of what was good and what was not good as to how to deliver vaccines to whom they were recommended. There was also a recommendation to develop a coordinated interagency plan. So the food program was run by a completely different program, the Department of Agriculture, and to reach out and work with them in linking immunization to their constituency. The government should reach out to medical societies to help achieve coverage. In the United States, a major group was the American Academy of Pediatrics, and I still work with the Indian Academy of Pediatrics, I forget the exact title for it, because they're very powerful as well. And then measure, hold people accountable, and support research on not only vaccines, but implementation research, getting vaccines delivered. And then when the Clinton administration came in, we got this childhood immunization initiative. And my bad joke is I went to a meeting at our Department in Health and Human Services in 1993, and they were throwing millions and millions and millions of dollars at me. Anything I wanted, I could almost get. There's nothing like a presidential initiative. And my bad joke is I left the meeting depressed, wondering if I had asked for enough. But the goal was to achieve 90% coverage, to have every state develop immunization action plans, to develop better measurement systems in all areas so they can pair and hold people accountable, develop disease elimination goals, and fix our vaccine financing system. And measles was a key in this. It was licensed in 1963, our combination measles, mumps, rubella in 1971. The effectiveness was 93% and 97% for 2 doses. So I'm going to focus on measles for the last part of the talk. And then the excellent safety profile over the last 50 years. And this is what has been going on with measles. The licensure, and this is a semi-log plot, so be careful. Vaccine was licensed in 63. We had 1 dose. We had a couple of resurgences here. We enacted laws in all states. We went to a 2-dose strategy and we improved preschool coverage. In essence, we interrupted preschool transmission, and measles was declared eliminated in the US in 2000. The elimination was interruption of year-round transmission. It required greater than 90% coverage of 2 doses, strong public health response to each case, which was resource intensive, and epidemiology of the measles during elimination was characterized by importations from endemic areas, limiting spread among non-immune persons. Therefore, we had an interest not only in immunizing our own population, but in supporting other populations. It's a win-win situation because we reduce importations, but more importantly, in those other populations that didn't have the resources to support measles, we were able to help them have a healthier population. And this is just a slide to illustrate some of my earlier points. And this is measles cases, and this is federal investments in measles. So when measles vaccine became available in 1963, and we had our immunization program in 1965, 66, resources went way up, measles cases went way down. Measles cases went way down, dollars went way down. Dollars went way down, measles went way up. Measles went way up, dollars went way up. Measles went down, dollars went down, measles went up. And so it illustrates the need that we have people born every day in the country. They don't arrive immune. We need to immunize them. We need to continue our dollars and our services. So this, again, led to the enactment and enforcement of all schools, not just measles. And in essence, this covered all vaccines and not just measles. So we used measles to build our overall immunization program. We led to financing to remove cost as a barrier, not just for measles, but all of the child vaccines. And it led to a national immunization survey measuring immunization coverage of all vaccines for preschool children, not just measles. And it led to 2 presidential initiatives, the first to push the mandates and the second to deal with preschool children. Now, what were some of the lessons learned? One is the need for a strong scientific base. Vaccine science, epidemiology, and health services are implementation science research. A limited number of measurable goals, an ability to compare and contrast good and poor performers, accountability. And one of the best examples I have was the state of Michigan. The state of Michigan was the lowest immunization coverage in our second presidential initiative in the Clinton administration. And the health officer in the state of Michigan used that information to get his state legislature to invest resources in improving Michigan's immunization status. So here's an example of data helping people become accountable. Developing key partnerships to build the political base. And as I said earlier, to me, one of the main ones was the American Academy of Pediatrics, because they had people who would lobby Congress, whereas I couldn't in the Centers for Disease Control and Prevention. And focus not only on vertical measles elimination, but also building the system. And one of my bosses at the Bill and Melinda Gates Foundation when I was there, we have programs that are considered vertical. That was smallpox, for example. We said, we got to get rid of smallpox and do what we need to do to get rid of smallpox. And then we have horizontal programs. We're going to build our overall healthcare system, and we're going to get the visits for child visits, et cetera. And diagonal is using a vertical group to pull in. And so a diagonal approach is what we use to build our overall system riding the back of measles. The last thing I want to talk about is the need to measure effectiveness in observational studies. Randomized, prospective, double-blind clinical studies done prior to availability of vaccine are no longer ethically feasible after vaccine is used. The term we use for vaccine efficacy is usually based on randomized controlled trials. Does the vaccine work? And it's usually pre-authorization, pre-approval. Vaccine effectiveness is real-world measurement. It's done in observational studies, and does the vaccine help people? The formula for calculation of vaccine effectiveness in percent is the incidence rate or attack rate in the unvaccinated minus the attack rate in the vaccinated over the attack rate in the unvaccinated times 100. Now, why do it? One is the real world performance of vaccines may not be perfect. There may be cold chain problems, that the vaccines were not stored properly, that the timing and completeness of the dosing schedule was different than the pre-licensure or pre-approval process and a different schedule. In the real world, it might be administered with other vaccines that theoretically might. Hello? Okay, and there could be a different epidemiology. For example, what we found in rotavirus is different populations. We needed vaccine in different populations that had a differential effectiveness. And so we needed to do separate dealings. And so am I muted?
Yes, you're fine now.
Okay. Address gaps in the evidence of vaccine efficacy for clinical trials. And this included severe disease, which might not have been looked at, death, looking at symptomatic or asymptomatic infection, looking at transmission, and then health specific workers, specific subpopulations, such as healthcare workers, the elderly, persons living with HIV, duration of protection, and particularly with COVID, but other groups, variants of concern. How well does the vaccine work? And then providing that information to regulatory and policy-making bodies that might change their recommendations. And this just shows you something we did developing the screening method. And what you have here is the proportion of the population vaccinated and the proportion of the cases vaccinated. And what you can see here is if you have a 90% effective vaccine and you give it to 90% of the people, if you have an outbreak, about 50% of your cases will be vaccinated. So basically, looking at the proportion of cases that are vaccinated alone can't determine what the efficacy or effectiveness is. And the screening method was to use a different method to determine proportion of the population vaccinated, such as immunization surveys, and then use that for the PPV, and then use the cases vaccination status for the PCV, and then determine the actual vaccination status. And other types of studies are cohort studies where you do surveys of the population, you determine who was vaccinated and who was not, you determine that for the cases, and you calculate the attack rate in the vaccinated and unvaccinated. You can do case control studies where the cases, you look at their vaccination and you compare it to control studies. A novel way of case control studies, and which has become increasingly popular, is something called a test negative case control study. And that is where you look at people with the same clinical syndrome. Those that test negative are your controls, and those that test positive are your cases, and you compare their vaccination status. And that gets rid of one of the potential biases and that is healthcare seeking behavior. The concern is that vaccinees may more likely seek healthcare than non-vaccinees, which could give you a falsely low vaccine effectiveness. If you look at people who are seeking healthcare, you minimize that bias. I've already spoke about the screening method, and regression discontinuity design is where you have an age cutoff and you look at the incidence rate in people for whom you recommend vaccination, and you compare it with that very small group of people very closely matched in age, but a little younger or older than the group that's recommended for vaccination. And a key issue is you need to determine true vaccine status. You need to have some record and not generally rely on parental recall. And this is just what I said about the test negative basis to minimize biases in healthcare seeking behavior. The other advantage is that all cases of control seek care at the same facilities, decreasing differences in access to vaccines. The vaccination status is usually obtained before results of the laboratory tests are available, so there isn't a bias there. And the test sensitivity and specificity needs to be high. If it is, then it should minimize misclassifications. Misclassification, there are weaknesses of it. It's not perfect, but it does offer advantages. Factors affecting epidemiologic studies are the case definition, and it needs to be uniform and specific for vaccinees and non-vaccinees. Case detection needs to be equal in vaccinees and non-vaccinees. Vaccination status needs to be determined accurately based on record of vaccination, ideally. There needs to be comparability of exposure of vaccinees and non-vaccinees, and risk factors for vaccine failure. If you find vaccine effectiveness is low, it should be looked at, such as age at vaccination, vaccine duration of immunity. So in essence, vaccines are some of the best tools in reducing disease burdens. A vaccine that remains in the vial is 0% effective no matter what the clinical trial showed. Disease surveillance is critical to monitoring immunization program success, not just monitoring immunization coverage. Measles, because it is highly contagious, is a useful indicator of immunization performance. A diagonal approach using a disease like measles can improve the overall immunization program, and it is critical to monitor vaccine effectiveness. Thank you. I'm happy to take questions.
Thank you very much, Walt. Wonderful, detailed talk and emphasizing very interestingly how vaccine rollouts are linked to politics, and they are also linked to the money that you are prepared to spend. May I take the liberty of asking the first question? You talked about rubella and measles elimination. Well, that is a realistic goal, considering that both of these viruses don't really have any animal hosts where they can go and hide. They only transmit between humans. Still, with measles, the R naught being so high, one would have to keep vaccination rates very high. So possibly the experience from smallpox and from polio, while it's a good guide, may not tell you the entire effort that you will need to eliminate something like measles. Your comments, please.
That's absolutely correct. I think that's why we use measles as the test, because it's a much greater test than polio or smallpox. And that's why we were able to use it to build the political support. And what was very helpful, Shahid, is that when measles would go down, people would think, oh, it's great. And then we would have real hospitalizations and real deaths. And so what happened is when measles goes down, the political community would often accept a low level as the upper limits of acceptability. And when it goes above that and people are dying, then there was more interest in investing in moving that forward. Rubella is certainly easier to eliminate. Rubella virus is less contagious than measles. The problem there is getting the political will, because the big problem with rubella is not most of the cases, but congenital rubella syndrome, and having enough data that will convince and get the political will to implement rubella. But I think the big issue is that's where it was important to reach out to partners who could work with the media, partners who could work with politicians. One of the big things about the Children's Defense Fund in the United States is they had groups of people who were journalists, people in the television media who could play a big role. In fact, one of the things we got was a front page article in the New York Times, which is one of the major newspapers in the United States, warning how bad our immunization coverage was. And we got all sorts of media attention. So that's where the public health establishment really needs to reach out with groups who have that potential. One of the groups that played a big role in globally was the Rotary Foundation in polio, and they helped get a lot of the political will. It's groups like that. We tried Lions or whatever that people need to reach out to and get aboard, and so that it is a coalition and not just public health people. I don't know if that answers your question, Shane.
Yes, yes. Rama, please go ahead. And for others who would like to ask a question, please raise your hand and I'll call you in order. Thank you.
Right. As always, Dr. Orenstein, it's a pleasure to hear you speak. I have a couple of questions, and I'll let Dr. Jamil, cut me off if it goes too long. The first question is, could you please elaborate the difference between elimination and eradication? That's my first question. And then the second question is, with respect to measles being a live virus vaccine and the policy and for vaccinating pregnant women, has that been revised, or is there any data to indicate that there's mother to fetus transmission or even mother to newborn transmission of the virus? So those are two questions. I have a third question, but I'll wait till the end.
Okay.
Thank you. Yeah.
The first one again, I'm sorry, was.
First one was, you mentioned there's a difference. You said elimination versus eradication.
Oh, elimination versus, great. Yes. Okay.
Yeah.
Eradication is the permanent absence. Eradication is forever. So, and the hope is with eradication that you won't have to continue your measures. That the measures for eradication, once you've eradicated, is an insurance policy. So, for example, for smallpox, we stopped all vaccination. And the feeling was if smallpox were reintroduced, such as a laboratory accident, we could get control of it. For polio, when we finally eradicate it, we still may want to do some vaccination because of concerns. If polio is eradicated, there may be laboratories that have the virus and don't even realize it, because the vast majority of polio infections, about 72%, are completely asymptomatic. And so there could be stools stored or whatever, and it could be reintroduced. That decision hasn't been made. Elimination is elimination in a certain area and where there is the potential for reintroduction, and you must continue your efforts on an ongoing basis. Does that answer that question?
Yes, very clearly. Thanks.
Okay. And
the next question was measles in pregnant women, measles vaccine in pregnant women.
Okay.
What's the policy, current policy? Yeah.
the current policy is not to vaccinate. The big concern in the US, which uses a combined measles, mumps, rubella, or measles, mumps, rubella, varicella vaccine, has been the rubella component was the major concern. And we did have when I was at CDC when I was young, we did have a registry where we would collect reports. And for the most part, we did not see any damage from rubella vaccination in pregnancy. But we still thought it was not a good idea to specifically recommend it in pregnancy. And so what happens is, should a woman with rubella unknowingly get vaccinated against rubella, we strongly recommend against taking an action like an abortion, because the data do show it is safe, but we don't recommend actually specifically trying to vaccinate pregnant women.
Got it. Thank you.
More questions? Hello?
I had a question. May I please ask it?
Sure.
Thank you so much, Doctor, firstly, for a fantastic talk. I wanted to ask your views on the question of patents in relation to vaccines. Do you first think that it's these patents that sort of reduce the speed of vaccinations? And, especially with the context of, the HIV outbreak in Africa, where, Pfizer and other such big companies had the drug, but were selling at these really exorbitantly high costs. And it was, an Indian company, Cipla, that came in and sort of introduced an alternative. And at least to my knowledge, laws have become more stringent about protecting the rights of these companies. So what are your thoughts on this? And do you see a solution?
That is a big concern. And I think what's very important, particularly with COVID, is that we need multiple vaccines, and at least the requirement for funding, and with a lot of government funding, at least there was some relief of some of the patent protection. I think what would be very important is for the world to develop a listing of what vaccines it most wants, and that there be government support of companies, for example, to help in developing those vaccines, and in return, the need to make the development more freely accessible, to sort of get company agreement. If you're going to fund if the government is going to fund all of the development costs, that they will provide some benefit that can overcome the kind of issue where vaccines are withheld from certain populations because the vaccines cannot be afforded. And that's where I think the other issue is. It's very important for high-income countries to help low and middle-income countries with their vaccination programs, because many of the pathogens are not only risks within low and middle-income countries, but are risks to high-income countries as well. And by helping low and middle-income countries, they help not only the low and middle-income country, but they help themselves. As I said earlier, a win-win situation. And I think that it would be good if we could develop a global system and get the resources for these vaccine developments. I don't know if that answers your question.
There are several questions in the chat box, and Lakshmi Kirola, would you unmute yourself and ask your question?
Hello.
Yes, go ahead.
Hello.
Yeah. Hi, Dr. Walton. Thank you so much for your wonderful talk. So I'm actually not expert in like immunology or immunization, but I just wonder a question regarding to COVID-19. So my question was, what do you think about COVID-19 life cycle, or I would say self-life? More genetic displacement will happen in future? What do you think about COVID-19?
I'm sorry. I think one, the virus is not going to eradicate itself. When you've got this much transmission globally, we're going to have not only a program to try and bring down the transmission, but we'll need to go have an ongoing vaccination program as new susceptibles are added to the pool. And what we don't know at this stage is whether we will get variants of concern that escape vaccine-induced immunity of our current vaccines, and we don't know whether there'll be problems with duration of immunity and whether boosters are really needed, and if so, how often. Countries like a number of countries have recommended boosters. So I think with COVID, what we need is continued ongoing research looking at who is getting it. Is it vaccine failure versus failure to vaccinate? If it's failure to vaccinate, what are the reasons? If it's vaccine failure, what are the reasons? And to take action with regard to that. I think you were asking about shelf life. Is that correct? Did I miss that?
Yes. I just wonder. I don't know it's the right question to ask, but I just wondering, like.
Yeah, that I don't know. That I don't know the answer.
Okay.
But we clearly know that they need to be kept at conditions, temperature conditions that are we use to give it its authorization or listing. And that needs to be, and then I think what we need is to continue to monitor how long the potency remains, and that then we can make recommendations for that. I presume there are expiration dates on the vaccines that go out, and I think at the moment we need to adhere to those expiration dates.
Okay, thank you so much.
Okay, Amrita Bhattacharya, please unmute.
Sir, am I audible?
Yes,
Am I audible?
Yes, you are.
Yes.
Thank you, doctor. That was a really interesting talk. I had a question, slightly specific question. You spoke about vaccination effectiveness. So is that solely based on like comparing the infection of a vaccinated versus an unvaccinated individual? Like, would it be like there are people who have allergic reactions or some side effects post-vaccination? So like, are they taken into consideration, or would there be any way to account for this in the calculation?
I think that you're raising a good point. What I am talking about is, given what is the risk of disease in vaccinated people compared to unvaccinated people, and wanting to know if the effectiveness is similar to what was found in the pre-approval vaccination trials. And if it's not, then to try and understand why, such as we're giving it to a different age group. There are people with underlying immune deficiencies that they're not making a good immune response, that the vaccine wasn't kept in the cold chain appropriately, and that there is waning immunity. And that you can tell, but the goal there is to look at vaccine effectiveness overall. It is possible, and it is important, that if you see in your regular surveillance that you're seeing a lot of vaccine failures, let's say in kids 12 to 18 months of age, for example, then what you can do is a study only in 12 to 18-month-olds. And you look at the vaccination status of non-cases and compare it to the vaccination status of cases. If they're equal, that would suggest 0% effectiveness. And depending on their difference, you could actually measure effectiveness. And then you could look at it versus in older age groups and see if the effectiveness is the same. So the methodology does allow you to look at vaccine effectiveness in subpopulations to see if the vaccine is less effective in those subpopulations compared to other populations or the general population.
Okay, the next person is Mrunmay Dalal. Please go ahead.
Hello, am I audible?
Yes, you are. Go ahead.
Yes.
Okay, so my question was, in case of a disease which has a high mortality as well as spread rate, and given that it's confined to a small area, what would be a better option, like the first option? Would it be controlling and trying to eliminate and eventually eradicate it, or developing an immunization program to prevent it from spreading to places that it hasn't reached yet?
I'm sorry, I didn't hear. What infection were you talking about?
So she's talking about a hypothetical infection.
Oh, a hypothetical infection.
Yes.
Okay. Yeah, I think that's a very important thing. I think we want to take action quickly. It can be frustrating because we've had a lot of false alarms. One of the reasons I hated preparedness. Somebody needs to do preparedness.
Thank you everyone for joining today, and stay tuned. We have one of these every month. Hopefully in October, end of October, we'll have Soumya Swaminathan, the chief scientist at WHO. But keep tuned. Thank you.